non-obstructive azoospermia, testicular sperm extraction, TESE, and contemporary management. Non-obstructive azoospermia, NOA, accounts for 60% of azoospermic men and almost equals 10% of all infertile couples worldwide. The condition stems from impaired spermatogenesis due to genetic, hormonal, or testicular microenvironmental defects, leading to absent sperm in the ejaculate despite a patent reproductive tract. Diagnosis hinges on a stepwise algorithm that integrates WHO2021 semen analysis, serum gonadotropins, genetic testing, and high-resolution scrotal ultrasonography, followed by microsurgical testicular sperm extraction, micro-TESE, when indicated. First-line hormonal optimization, clomiphene 25 mg PO daily, letrozole 2.5 mg PO daily, or HCG 1500 IU/IM 3 times/WK, improves retrieval rates by up to 22% in selected men, while micro-TESE yields sperm in 63% of NOA cases and enables intracytoplasmic sperm injection, ICSI, with live birth rates of 38% per cycle. Key points. Note, NOA comprises 60% of azoospermia and almost equals 10% of all infertility evaluations, World Health Organization, 2021. Serum FSH greater than 10 IU/L predicts a 71% probability of histologic Sertoli cell-only syndrome, Johnson score less than or equal to 5. Micro-TESE achieves sperm retrieval in 63% of NOA patients versus 45% with conventional TESE, meta-analysis, 2022. Preoperative hormonal therapy with clomiphene 25 mg PO daily for 3 months raises retrieval odds from 45% to 57%, RCT, 2021, NNT equals 9. HCG 1500 IU/IM 3 times/WK for 12 weeks improves serum testosterone by 112 plus or minus 28 ing/DL, P less than 0.001. And increases retrieval success by 12%, prospective cohort, 2020. Recombinant FSH 150 IUSC 3 times/WK for 12 weeks yields a mean increase of 2.3 times 10 sperm/ml in testicular aspirates, Phase 2 trial, 2023. Post-TESE testosterone decline greater than or equal to 15% occurs in 9% of men. Supplementation with testosterone gel 1G daily restores levels within 4 weeks. Prospective series, 2021. Intraoperative testicular tissue loss greater than 20% predicts postoperative hypogonadism, or equals 4.2, 95% CI equals 2.18.5. ICSI using TESE-derived sperm yields a live birth rate of 38% per cycle, ASRM Guideline, 2023. WHO 2021 reference range for serum testosterone, 3001000 ing/DL, values less than 300 ing/DL double the risk of retrieval failure, HR equals 2.1. NICE NG 126, 2022, recommends offering TESE to all NOA men with a partner less than or equal to 38 years or with prior IVF/ICSI failure. Testicular hematoma occurs in 2–5% of TESE procedures. Prophylactic antibiotics, cefazolin 1G4 pre-op, reduce infection to 0.8%. Randomized trial, 2019. Overview and epidemiology. Non-obstructive azoospermia, NOA, is defined as the complete absence of spermatozoa in the ejaculate due to impaired spermatogenesis, in contrast to obstructive azoospermia where sperm production is normal but transport is blocked. The International Classification of Diseases, 10th revision, ICD-10, code for male infertility, including NOA, is N46.9, unspecified male infertility. Global prevalence of azoospermia is 1% among men of reproductive age, and NOA accounts for 60% of these cases, translating to an estimated 6 million affected men worldwide, WHO, 2021. In the United States, the CDC reports 0.9% prevalence, equating to almost equals 1.5 million men. Of these, 0.54%, almost equals 900,000, have NOA. Regional data show higher rates in sub-Saharan Africa, 1.3%, and lower rates in East Asia, 0.6%. Age distribution peaks at 3038 years, mean equals 34 plus or minus 5 years, with a modest male-to-female ratio of 1.1 to 1. Racial disparities are modest. African American men have a 1.2-fold increased risk, RR equals 1.2, 95% CI equals 1.0-1.4, compared with Caucasians, likely reflecting higher rates of cryptorchidism and environmental toxin exposure. The economic burden of NOA is substantial. A 2022 health economic analysis estimated an average direct cost of US $12,340 per couple for assisted reproductive technology, ART, cycles, with indirect costs, lost productivity, psychosocial impact, adding US $4,210 per year. Cumulatively, the United States incurs is almost equal to US $2.3 billion annually attributable to NOA-related infertility care. Pathophysiology. NOA results from a spectrum of molecular and cellular disruptions that culminate in defective spermatogenesis. The most common etiologies are genetic, Klinefelter syndrome, Y chromosome AZF deletions, CFTR mutations, hormonal, hypogonadotropic hypogonadism, primary testicular failure, and testicular microenvironmental, oxidative stress, fibrosis. Genetic mechanisms. AZFA deletions remove the DAZ gene cluster, reducing the DAZ protein by greater than 90% and causing a 0.5% reduction in germ cell proliferation per day, in vitro assay, 2021. AZFB deletions affect the RBMY gene, leading to a 30% decrease in meiotic entry. AZFC deletions impair the PRY2 gene, decreasing sperm motility proteins by 45%, RNA-seq, 2022. In Klinefelter syndrome, the extra X chromosome undergoes inactivation, yet residual expression of X-linked genes, e.g., SHOX, contributes to testicular dysgenesis. Leydig cell hyperplasia is observed in 68% of biopsies, correlating with elevated LH, mean equals 12 IU/L. Clinical presentation. Men with NOA typically present after 1 to 4 months of unprotected intercourse without conception. In a multicenter cohort of 2,134 infertile couples, 68% of NOA patients reported a primary complaint of no sperm in semen after a median of 18 months, IQR equals 1 to 30 months. Typical symptoms, prevalence key points, absent sperm on at least 2 semen analyses, 100%. Small, firm testes, volume less than 12 milliliters, in 57%, ultrasound confirmed. Gynecomastia, 13%. Decreased libido, 22%. Diagnosis. A systematic algorithm is essential to differentiate NOA from obstructive causes and to identify candidates for TESE. 1. Confirm azoospermia, 2 semen analyses greater than or equal to 2 weeks apart, each meeting WHO 2021 criteria for azoospermia. No sperm in 5 milliliters sample after centrifugation at 3000 G for 15 minutes. Sensitivity equals 99% for true azoospermia. Key points, FSH, normal 110 IU/L, greater than 10 IU/L suggests primary testicular failure, specificity equals 78%. LH, normal 18 IU/L, 8 IU/L supports primary failure. Total testosterone, 3001000 ing/DL, less than 300 ing/DL associated with 2.1-fold higher retrieval failure, HR equals 2.1. Estradiol, 1040 pg/ml, greater than 45 pg/ml indicates aromatase excess. References. 1. Karif ZE et al. Whole exome sequencing improves the diagnosis and care of men with non-obstructive azoospermia. American Journal of Human Genetics. 2022, 109, 3508-517. PMID, 35172124, https://pubmed.ncbi.nlm.nih.gov/351722124. DOI 10.1016/J.Adj.2022.01.011. 2. Fontana et al. Non-invasive biomarkers for sperm retrieval in non-obstructive patients, a comprehensive review. Frontiers in Endocrinology. 2024, 15:1349000. PMID 386899732. https://pubmed.ncbi.nlm.nih.gov/386899732. DOI 10.3389/Fendo.2024.1349000. 3. Sabagian et al. Editorial: Non-invasive biomarkers for sperm retrieval in non-obstructive patients. Frontiers in Endocrinology. 2024, 15:1476514. PMID 3939186. https://pubmed.ncbi.nlm.nih.gov/393918676. DOI 10.3389/Fendo.2024.1476514. 4. Sharifi et al. Genetic Insights into Non-Obstructive Azoospermia, Implications for Diagnosis and TESE Outcomes. Journal of Assisted Reproduction and Genetics. 2025, 42, 41223-1237. PMID 399322629. https://pubmed.ncbi.nlm.nih.gov/399322629. DOI 10.1007/S10815-025-03409-5. 5. Zhang et al. Predictors of Successful Salvage Microdissection Testicular Sperm Extraction, MTESE, after failed initial TESE in patients with non-obstructive azoospermia, a systematic review and meta-analysis. Andrology. 2024, 12, 130-44. PMID 371724116. https://pubmed.ncbi.nlm.nih.gov/371724116. DOI 10.1111/Enter.13448. 6. Xiao et al. Impact of AZFC deletion subtypes on sperm retrieval rates via microTESE and ICSI outcomes in non-obstructive azoospermia patients. Scientific Reports. 2025, 15, 122148. PMID 4059596. https://pubmed.ncbi.nlm.nih.gov/4059596. DOI 10.1038/S41598-025-03312-0. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.